I am going to start out by asking for a volunteer. No magic tricks, no boxes, no saws. I just need somebody to help me with something here that I want to just kind of use as a visual, and it's painless. Yes, sir, thank you. Sure. I'm going to ask you, this is like the Dead Sea Scrolls. You got to be very delicate. Okay. Just unroll this slowly. I've got it on a little tight, and it's just tape. Let's see how this works. Okay. And just keep going.
All right.
You'll find out soon. You're getting close. I need a little more.
Thank you.
You're going to run out. Okay, that's fine. Well, if you make the wall, I can't ask you to go any further. That's good. All right. So that'll stay. Thank you. So I know I've got people from the department here, and they probably know what this is, so they can't play. But I'll ask anyone else here to just take a guess as to what this 64 pages might be. Any ideas? And it's from the Department of Health and Human Services. I wouldn't expect you necessarily to know, but this... blood pressure measure, no, but it's probably on this form someplace. Everything else is. This actually, believe it or not, still in the year 2016, is our common application for assistance programs. When folks come into our doors and need Medicaid, food assistance, cash assistance, emergency relief, and job support, this is what about half of our people still experience. And I'm glad to say more and more people are moving into the electronic application, but we still have about, I think, 40% of our folks that come in to the department completing these 64 pages. And it's not what we want to do in government if we want to get serious about getting people into programs that can help them quickly and move on to a better place, whether that be independence or just getting the better supports they need. This is a very effective form if you want to keep people out of programs. And so the reason I use this when I start these presentations is to just kind of give you a sense for what we're still up against in the year 2016, even as we continue to develop more IT and we continue to strive for better exchange of information, we still have folks that encounter this. And this is really kind of an illustration of why it was so necessary for us to become the Department of Health and Human Services. We have operated large programs independent of each other for many years on the health and human services side, while at the same time touching the same clients. And that's a frustration not just for the clients that we serve, it's a frustration for our caseworkers, what I like to now term success coaches, and we'll talk a little bit more about that, how we want to move from what people think of as a conventional caseworking into a success coaching model. Yeah, it's a frustration for them as well, because a lot of people get stuck in this quagmire, and we're not able to address the root cause of their issues because we're kind of all trying to muddle our way through a system that I kind of term as making widgets rather than serving people. And part of the reason that that has occurred is we've really built government in many respects around the bureaucracy to serve the bureaucracy rather than serving the people that need the help that we are here to provide. And so we need to reimagine how we deliver services and how we focus on the individuals that we're serving more so than the bureaucracy that's providing those services. And that's what we call integrated service delivery, and it certainly is going to be dependent upon sharing health information and sharing the data that's already available across the systems that exist. So I kind of wanted to just lay this out. My compliments to Michael Brennan and the team down at Sevilla in Detroit, doing a lot of cool things down in Tech Town. He kind of put this together for me. I first saw this back about, I think, late fall. He asked me to come down, and he said he was doing some pretty cool things on his own, really, with no input from the department until he called me down. He said, we want to really have a better experience for the clients that we're serving. So from a client perspective, Michael Brennan and his group started to dive into our application and just say, how do we simplify this? and how do we better serve the clients that we're all here to serve, and how do we make this work for them. So Brennan's team had this thing taped up in Tech Town in an open warehouse on a 12-foot wall, kind of doing the same thing I did here, but he started way up on the wall and had it rolled across the floor, and I couldn't get to the other side without stepping over it. And he did this on purpose so he could actually force me to kind of see what's on the application, because I didn't really have a clue. I came from the community health side, and I had some awareness of what was going on in the human services, but we're only a year into this thing, and so I'm still admittedly learning a lot about what goes on in health, in the human services side, and how we interact with the clients we serve. So I think Michael intentionally walked me over page 14 just to kind of show some of the stuff that we put our people through, and he said, take a look at page 14, and I looked down at page 14, and it's a page that's dedicated to children in the household that are under age of 22, and there's a lot of information you need to fill out in these forms. And on page 14, he says, look about halfway down the page, and I did, and we asked for that child's conception date and place of conception. And I thought, so my first question was, and Cynthia maybe knows, having been on Medicaid for a long time, why we might need that. I don't. So my first question was, why? And then I said, who keeps those records? So I don't know. And I think this is what happens when we build programs on top of programs, and we don't necessarily take that step back to just reevaluate from a holistic perspective. Is it meeting our goal of serving the client in the most effective way? And so that's really what I want to talk to you about this morning. First off, I do want to thank all of you in this room and MiHIN and all of our other partners that really have helped us move forward, whether it be on the former community health side, where I've had more than 8 years of experience, or the human services side, or now the combined health and human services. Our success really is dependent upon the successful partnerships that we have with all of you. So I'm really impressed when I was just kind of going through some websites in preparation for this. I had told Dr. Pletcher this morning that I didn't realize MiHIN had only formed in 2010. It seems like you guys have done a whole lot in a short period of time, so I just assumed that you'd been around longer than that. So tip of my hat to you for everything that's already occurred in just 6 years. But one of the statements in the mission for MiHIN that really resonates with me and is in line with everything that we're trying to do here is making data available at the point of care. And so what we've been trying to do in health and human services over the last, now it's been about 14 months that we've been together as a family, is get services to people. We can no longer expect in this day and age to have clients come find us, especially when they're in a crisis in their life. We need to go where they are, meet them where they are, in their home, in their places of employment, in the schools, as we're doing through Pathways to Potential. And that's critically important, I think, to moving the systems forward to better serve the people that we need to serve. The other thing that really stands out to me that you've all been working on, the Master Person Index, which will certainly be critical for our success as we move forward as a merged department. Now that we're sharing systems and information across those systems, we're going to make sure that we have a way to effectively serve the client so that client is not filling these types of forms out at MDHHS, at community service providers, at community mental health agencies. This is just one experience they have, and they do this over and over and over again. So we certainly need to be better about sharing that information. I think the Master Person Index will allow us to do that. I'm intrigued by the use cases, and MiHIN's already starting to partner with the department through data sharing scenarios. We're doing some through immunization queries and newborn screening in particular, and I think those are going to be important as we go forward to proving that this will, in fact, help us succeed. So a little bit about where we are now that we're the Department of Health and Human Services. The order from the governor was effective in April of 2015, so somebody just stepped on my application. That's okay. We're 14 months in, and I feel like we've come a long ways, but we've got a long ways yet to go. As separate departments, certainly we recognized, as I had already mentioned, that we were already touching the same people. So just using Medicaid as an example, we had human services directly interfacing with those Medicaid beneficiaries on the ground through all the local offices. And then on the community health side, we were making the payments to our providers and interacting with the service providers. So really, a lot of this started to accelerate as we recognized through our work and trying to get Healthy Michigan passed that we could do a whole lot more together as a combined department than what we could do separately. The teams that came together from the two former departments as we brought Healthy Michigan up really demonstrated the power in having these teams unified. We put up some large system changes in a very short period of time, many policy changes. We had to certainly make sure we were ready on the ground and making adjustments with field staff, and everybody really rose to the occasion. Happy to say now that we're serving more than 600,000 people in the state of Michigan through the Healthy Michigan Plan. It's been a big success for all of us, not just the department, but for the entire state and for all of our partners here that have helped us with it. And it demonstrated what we could do together. We've no longer, we've come to the point where we're no longer going to be pointing fingers at each other. I think that was a tendency we had in the past when audits would come out and we'd have eligibility determination error rates that just astounded me. On the community health side, we couldn't understand that was, and on the human services side, I think they were equally frustrated with us about some of the things that were occurring. Now we've got a great opportunity to say, hey, we're going to move forward together and we're going to fix the issues that will help us better serve the state of Michigan. One of the things that we've done to this end is we've created in the department what I call the Business Integration Center. And the Business Integration Center kind of pulls out the IT and the project management expertise that were primarily focused in Medicaid, very heavy in Medicaid. We had a lot of smart folks in Medicaid working the IT and the project management issues. And we knew that that was serving Medicaid very effectively. As a combined department, we knew we were going to need those folks to serve the entire department effectively. We needed to span the organization. So we took one of the silos, and we converted it from a vertical to a horizontal. The Business Integration Center now spans the entire department. That allows us to bring those IT and PMO expertise across the entire organization, pull in the folks that they need from the different subject areas, and work together to advance our cause. It gets buy-in from all of the administrations, whether that be behavioral health, population health, the children's services and field operations, and on. And we're now working across those organizations through the Business Integration Center, and I think will set us up for success as we go forward with major initiatives. So I want to talk a little bit here about where we have been to this point and where we're heading. So when I talk about integrated service delivery, it's really a vision to just simplify the client experience and provide the success coaching that we think is essential to help the clients we serve move to a better place in their life. So on the left side of this slide, what you kind of see is the today, what is kind of program focused is what I like to say, and then where we want to be tomorrow. And in some respects, we're already starting to get to tomorrow, and I'm pleased to see that, and that's person focused. So right now, you look at the left side, we tend to be very transaction and enrollment focused. We want to be holistic, proactive, preventive. That really is all about moving away from these forms and getting to a place where we're taking that step back and asking, what is it that brought that client into our doors to begin with? We have a tendency, and why I call it making widgets, we deem people eligible. If they can get through all of this, and not a lot of them do on the first attempt, they get into the program, and basically it's a pat on the back, welcome to the program. We'll do a redetermination in 12 months. They might still be eligible. They continue in the program. And in many cases, we don't have the time to just stop and say, okay, you qualify, but why did you qualify? What life circumstances brought you to us? And that's what we really need to be about. If we're going to make serious change and we're going to better serve people, we need to help them get to the heart of the issues that they're dealing with. And that's what I talk about when we want to be holistic, proactive. We're siloed by nature. Governments tend to be that way. Bureaucracies kind of build these silos. It's just inherent part of being part of government. We want to be more collaborative with our service providers, both inside and outside government, not just federal partners and local governments, but also all of our vendor partners, all of our local community service providers, and we'll talk a little bit more about how we intend to do that. We have manual processes, as you can see, that just add layers of duplication. Actually, when I was down at Sevilla talking about this 64-page application, I was also informed, as they had interacted directly with some of the clients we serve, that many of these people, and obviously you know that we serve people that are in these programs because they have serious needs, primarily based on income or lack of income. And I find out that many of our clients have to hire attorneys just to get through this, and that's kind of sad. So we need to certainly find ways to move beyond the manual and become more automated and help our clients navigate this process more effectively. That's going to require more investment in information technology. We don't necessarily need new systems. What we need is the ability for systems to communicate with each other, and I'll show you what we intend to do there. Moving from the program focus to the person focus, I've already spoken to that a little bit. We tend to have some limited supports that focus on a finite segment, and what I mean by that, if I've got a client that qualifies for Medicaid, cash assistance, food assistance, you've even heard the governor maybe speak to some of this before as we were rolling out the executive order and creating the new department. We've had a tendency to segment people into those programs, and you can't really serve that person and get to that person's core needs unless you're looking at that person rather than the segments in the respective programs that they're in. So this requires us to take that holistic approach and look at that entire person's needs. We have overloaded caseworkers, and I'm going to speak to you a little bit here in a few minutes about just what some of those caseload numbers are. They're astounding, and I am just amazed at the job that our caseworkers do each and every day as I've learned more about their lives as the new department. So we want to be in an environment where we have caseworkers that are focusing on people, and that's going to require us to move some of the more menial tasks that they're currently having their attention diverted to free them up to have that direct interface, the meaningful time with the clients that they're serving. So here's a little bit about how we're going to do this. We call this the Integrated Service Delivery Strategy. I've mentioned that a lot of this is going to happen through IT. A lot of this is going to happen through interaction outside of our offices. One thing that's already occurred, and to the credit of the team that was in Human Services before we even merged, they had already rolled out Pathways to Potential, which I really love. Pathways to Potential is a program where we're taking our caseworkers out of the local offices and into the environments where our clients reside. We started in schools, and we have caseworkers that are right in the school all day, every day. And these are people that the students see on a regular basis. They become very comfortable with them. They open up on issues that they wouldn't otherwise, and as a result, we're able to identify needs that not only that child, but their entire family might have. An example of this, in Kalamazoo County, we have a young man by the name of Kevin who had been coming to school, but kind of sporadically, on and off. After a few months of becoming more comfortable with that success coach that he was seeing in the school, he was able to approach that success coach, the pathway worker, and let that pathway worker know that essentially he was hungry, he was homeless, having trouble getting to school. There were transportation issues outside of the bus routes. And working with Kevin, the the success coach was able to address those needs that that family had, but also the health needs that Kevin had, finding out that he was diabetic and getting the help he needed to address his diabetes. And I think that's something that might not have happened. Kevin might have continued to flounder without that success coach and that pathway worker being right there in the school. So I think it's going to be cool. We want to see more of those success stories because we know there's a whole lot more Kevins out there. How we intend to do this, integrated service delivery, we have 5 major component areas that we intend to address. So the first one, I talk about this integrated service delivery portal, and this is where I've mentioned we have multiple large systems already. In our department, many of you are already aware, we have a large SACWIS system dealing with child welfare. We've got the Bridges system handling eligibility determination and other things. We've got CHAMP systems making payments. I've got caseworkers trying to navigate all of this and find their way through these systems as they're working with clients. What we need, not necessarily new systems, but we need that platform that will connect those systems and allow those systems to feed information to a single profile. And that's really what the health information exchange concept's all about. It'll be one place that that caseworker or success coach and that client can share and see the same information. And it's also a portal that will be shared with our community partners so that no matter what door that client might walk through, their information is already available and it will be seen by those that need to serve them. And that'll be a huge step forward so that those clients can get beyond that frustration of having to repeat their story 10, 15, 20 times. That information should be there. We should be sharing it. We intend to do that through this portal. We will have a person-centered service modules. This will simplify the client experience. This, again, is about sharing data with consent, and we've worked on some of this already with MiHIN through the behavioral health consent, which is very important to move us forward. Sharing that data is critical to identifying those needs, and especially those needs on those clients that have such significant circumstances that they often don't even know what they are asking for. And with those consents, we're able to more actively engage them in a meaningful way in many instances before they reach a more serious crisis. This will include common assessments to holistically identify a person's needs and goals. The success planning that I'm referring to is all about goals, and those goals are not set by our caseworkers. Those goals are established by the clients we serve, if need be, alongside a success coach, but it's all about helping that individual achieve their goals and move to a better place. We'll have a single entry and connection, so no matter where they might go through the system, it's important that they have that success coach going with them for that entire experience. We will have consistency in exchanging information and determinations across all programs and minimize the request to customers and also minimize that administrative burden for employees. And again, that gets back to eliminating this, getting down to the essence of what we need from them and just moving forward. Oops, I didn't mean to fast forward just yet. Got a few more there. Universal caseload management, I think, will be important to help us succeed. One thing I've really come to respect as we've merged into one department, I had always heard this while I was on the community health side, that caseworkers were just overloaded in human services, but I had no appreciation until I came into the chief deputy role for the combined department as to just how much work these folks do, and to be able to pull off what they pull off and still come in and have time with clients is just amazing to me. I have eligibility specialists in the department right now that have average caseloads. This is average caseload statewide, and this is last year's data, and I think it's gone up since then. 592 cases on average for a caseworker as an eligibility specialist, having to handle income and assets and divestments and trusts to determine the eligibility for these folks in the programs. And those range from a county at 315 to one county up to 776 with an average caseload. Cash assistance, I have average caseloads of about 260 dealing with employment issues and participation requirements. And that range is anywhere from 79 in one county to 825 in one county. And the point being, with that disparity, What we need to do in universal caseload is we need to get beyond dislodging our employees and moving them from county to county because the needs change all the time. We need to get to a point where we can share that information so that we can relieve some of that burden, not necessarily moving the caseworker, making sure that that caseworker still has that common contact with their client, but pushing some of that back-end work like the income verification, the other case file work to the other areas that might be a little lighter at that time. So universal caseload management will be important to help us succeed in this because we've got to make sure that the caseload is manageable. A contact center development. Call centers have always been an important part of our success in the Department of Health and Human Services. We, on the community health side, always thought that the contact centers were fairly easy to work with the federal government. And then when we became Health and Human Services, I was introduced to the USDA and the FNS folks, and I thought, oh boy, we got some work to do. And we're going to continue that work because we need to get to a point where we can allow our merit employees to have more time with the client. And the only way that works is if they're not taking calls where they're simply doing things like address changes, family status changes, the types of things that take them away from spending that time with the client and helping that client move to that point of achieving their success. So we need more automated systems there. We need to reduce the calls that are going to the caseworkers. We need to provide real-time information and resolution. We certainly need that flexibility from our federal partners, and we intend to use the call centers to improve our experience for the clients and job satisfaction for the employees so that those caseworkers aren't spending up to half their day just clearing voicemails and spending time logging into the systems. This frees them up to be the success coaches that we need, and in my opinion, it really humanizes the process because now we're having that meaningful time with the clients. Lastly on this slide, the technology infrastructure modernization. We're going to need better connections and information exchange between systems. I've mentioned that already. We've got very powerful systems. We've got great data warehouses. We need to find a way just to bring that together and make sure that exchange of information is occurring. This will allow that success coach to see that single profile using that platform. I dream of the day where I have success coaches that don't even know we have a SACWIS or a Bridges or a CHAMPS. That's really where we should be. They should be able to call up a profile to serve that client that they need, and they don't need to worry about logging into large systems. That work's all occurring behind that screen. So that really, I think, will be huge for us. I think we can do it, and I think we have to do it if we're going to serve our clients effectively in the future. Some of the core concepts and components of this integrated service delivery all hinges on the success plan. For me, that's what it all comes back to, and the people in our department hear that from me time and time again. If we do nothing else, we need to get to a point where we're working a success plan with the client, where we are getting beyond just enrolling clients in programs. We are asking that client, how can we serve you to help you move to a better place?
Can you hear me now?
That might be complete independence for some. It might mean that they're going to continue to need to have our support and be in some programs, but get some job skills training to move on to a more meaningful employment, gainful employment for them. It could just mean that they need better nutrition and access to food for their family and their kids. Could mean any number of things, but these success plans will be critical, and I think it brings dignity to the process and to the clients that we serve, and that will be vitally important for us. So the success plan is what everything comes back to for me. We're going to orient to meaningful outcomes through those success plans. We'll empower the clients that we're serving. I've had many people kind of describe the current environment as the caseworker being up here and the client being down here, and I don't think that is by intent on the part of the caseworker. I think it's just the system that we're in and the overload that they're experiencing. If we can have more time between the client and the caseworker, I think we balance that, and we have more of an equal plane where that caseworker certainly feels that they're part of the process, they're being heard, and they're vested in it. And that will certainly help them to regain that dignity and to take control really again of their own life rather than feeling it's out of control and in the hands of everyone else. So I want to kind of wrap up by just saying that these are ideas we've had not only within the department, but without, and working with partners inside our government, but also outside with vendors and others. It's going to be important for us as we move forward that we bring those best ideas together. These are just some of our ideas now as we're a year into it. I don't pretend that these are all the right answers. I certainly think we're going to jump a couple of giant steps forward with this, but there are other things that we're going to need to do together. You already know that we have the state innovation model. That's also going to be important as we move forward to have help from our partners on the outside to make sure that state innovation model is successful, that we have the common health infrastructure to expand population attribution and other things there. We have health information to non-health care through children's services, and that will be role-based mechanisms that will help us move forward in that area. So we've had a long history together with our partners in this room, and even some that are not here. We're going to need that continued partnership to succeed as the Department of Health and Human Services, and I look forward to our department continuing that journey with all of you, and I thank you for that. I've got maybe just a few minutes before we move into the next part of the agenda, and then I introduce our next speaker. So if anyone has a question or two, I'll be happy to entertain that and see if I can address those for you.
Can you hear me now?
Yes. Hi, Dr. Hlomka. I can hear you.
Yes, sir.
Oh, very good. You see, sorry, there were two Davids here. We have, we have got a Don Moody, we got a Samantha. Now, Samantha sounds particularly like the movie Her. Are we sure we're not, gotten a computer who's giving me instructions here?
No, I don't think so. At least she's not hinted that that's who she is.
So the question, we've got a microphone coming around, but I'll just repeat that one.
He's going to
The
take some
question,
and then
if I understood it, was caseworkers interacting with the clients
we'll try to get the audio going so
and health systems. So as we've worked through this, we've actually had caseworkers in the room kind of developing a lot of this with our folks centrally. So we brought them in from across the state, urban offices, rural offices, and we've engaged them to understand their experience and ask them, how do we get to that point where we're freeing you up so you can have that time with the clients and our other partners, including health systems, to make this a successful model. We don't want to develop something that's going to fall flat. So we're going to be careful to continue to engage those caseworkers as we move forward. But these are the concepts we're hearing from them that they need to have that time to be able to engage our partners and the clients. Right now, there's not enough hours in the day. And so really it's all about implementing these caseworker, I refer to them as caseworker relief initiatives. If we can do caseworker relief, we can free that time up, then we can get those caseworkers to a point where they can engage the clients and other partners to move forward in the new service model. But it's only going to happen if these mechanisms are in place, because otherwise there's just not enough time to get it done. There's just that much work to do. Yes, sir.
I was like Kevin maybe 40 years ago, and I just wanted to thank you for trying to help. I know the people that helped me were overloaded, and there was a lot of kids that didn't get help, and I hope that you can increase their capacity because they saved my life.
No, thank you. I'm glad to hear that. And it really tugs at my heartstrings when I hear these stories from the people. Our caseworkers in the trenches are heroes to me, and I think they do great things, so thank you for that. Over here.
I was at a presentation with another state Michigan department, and they were talking about an initiative Michigan-wide to have a common statewide portal for people to access all of their state needs and register and do those things. Is this going to be part of that rollout?
Yes, great question. So the question is whether or not this becomes something that goes statewide across other departments. I absolutely believe it will. We're the largest department. I think this could become a natural springboard to carry us across the entire state government. And that would include all of us in this room. It doesn't matter whether you're in assistance programs. I hope there's some day where I can go in and do everything I need to do, renewing my license tabs and all that stuff, going out and getting fishing licenses, on, a single profile. So absolutely, that is our intent, is that this becomes a profile that really springboards beyond health and human services.
Is there a role for community organizations or social service agencies not affiliated with the state? Because they provide a lot of the kind of auxiliary, ancillary referral from caseworkers. I'm talking about, neighborhood organizations and churches and United Ways and organizations like that.
Absolutely. And I'm glad you asked that. I've spoken about that in prior presentations on the same topic and failed to do that here, so I'm glad you asked the question. I really think, if done right, the Common Portal does allow those other community organizations to serve the client. I don't believe that everybody has to come through one of our employees or through the department to get the services that they need. And it's possible they might not even have to start with us to get into the programs that we administer. So I think the community service organizations certainly will be a big part of this if we have that common portal. The idea is to serve that client wherever they are. And if they first approach that community service organization before coming into the department, absolutely, I want to make sure that we're partnering so that we can get them what they need, whether it be directly from us or through a community service organization. So there'll be a big role for them, in my opinion, going forward if we use that portal the right way. I'll do one more, and I want to keep us on schedule. I'll be happy to stick around afterwards as well and answer any questions if you're more comfortable doing that one-on-one. I'm happy to do that. Okay? So I want to thank you for your time. Appreciate you having me here this morning, and I enjoyed being with you.